Tes satu, tes satu, tes satu, satu. Tes satu.
Maybe we can start. Check.
Cek. Cek satu. Sudah, Mbak.
Cek 1, 2, 3. Okay, good morning. How are you today? I hope you are all doing well. On behalf of the Master in Tropical Medicine, in collaboration with Master in Biomedical Sciences, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, I would like to warmly welcome our participants to today's international guest lecture. Thank you very much. This is from the Pathological Anatomy Study Program. And then from Tropical Medicine, thank you very much for joining us today in person or online. Thank you very much. Oh, is it okay? Yes. And also, the one and only, we are honored and delighted to our distinguished guest lecturer, Professor Chuang Hsiao-Chi. Yeah. Thank you very much for sharing your expertise today in Universitas Gadjah Mada in your environmental health risk and pollution-related diseases, emerging health challenges. So, Prof. Chuang and us, yeah, and all here have a long collaboration, and I hope we still, our collaboration will still sustain until a long time later. And then I would also like to extend my appreciation to our moderator, Dr. Vincent. Thank you very much for serving as the moderator and facilitating today's discussion. And this topic is highly relevant to the health challenges we face today, and I hope this session will provide valuable insights and inspire meaningful discussion among our participants. Thank you, Prof. Chuang, for being with us today, and thank you to all participants for joining in this event. Yes, welcome. Without further ado, I would like to invite moderator, Dr. Vincent, to begin the facilitating Professor Chuang's lecture. Thank you very much.
Thank you very much, Dr. Kala, for the introduction and also for the warm welcome to our participants and also to Professor Chuang. I'm Vincent. I'm from the Department of Radiology. I'm honored to be here to help moderate this event, which is the visiting professor and guest lecture from our speaker, Professor Hsiao-Chi from Taipei Medical University. So first, before we start our presentation, we will introduce a little bit of our speakers today. So Professor Hsiao-Chi is a professor in the School of Respiratory Therapy in Taipei Medical University. He's also a graduate of Ph.D. in Division of Pathophysiology and Repair, School of Biosciences, Cardiff University from UK. And actually a little bit background story. So Professor Chuang is also my supervisor in TNU. So he's the one who supervised me. Although as I can say, for the 3 years of my study, I only absorbed a little bit because his knowledge is a little bit vast. But he's willing to share a little bit of the knowledge so that we can learn today about the updates in the environmental health risk and also pollution-related disease, which is a big topic in our department in the Taipei Medical University. So I guess without further ado, we will let Professor Chuang to present his findings and presentation. Please, Professor Chuang.
Shall prepare some notes. So please allow me to end my form. Selamat pagi and Samuyana yeah, yes. And saya Hsiao-Chi Chuang. Yes. Minum paket suatu Kipomakan, yes, and Kibahagiaan, yes. Pagi saya untuk kembali ke UGM hari ini. And it's really my honor, and I spend more time to visit rather than my slide, but it's really difficult. And it is quite honor for me to be here, and I'm also the advisor for the EMU Biomedical University Student Indonesian Student Association. So actually, I do a lot of practice during the student activities, but in fact, there are a lot of students. They are my teachers. They not really try, but they correct me regarding my pronunciation. But I still want to try it because I think there will be more courses, and it would be great for the start. I'm Hsiao-Chi Chuang, and it will be honored to be here. As I say, because I've been to UGM several times and know the data and Vincent and validated for a really long time. And today I'm going to talk about environmental health risk and pollution-related disease and the emerging health challenges. I try to explain what's air pollution and what's climate changes and how will that be affected our daily life in terms of like the clinic or like well-being conditions in the future. So today I'm talking about the risk between air pollution and COPD pathogenesis. And then I'm talking about the phenotype or air pollution that related to COPD. And then how's the effect of air pollution on COPD after climate changes. So air pollution is really an important public health issues about 92% affected by air pollution. And in our daily life, such as in Taipei, the major emission sources are like the traffic emissions, such like scooters, cars, or in the other cities in Taiwan, that will be a lot of like factory emissions. So this is pictures from Vietnam, and see a lot of like the traffic emissions in the city of Ho Chi Minh. And in their daily life, they use biomass burning for like the cooking, eating, and so on. So it's a life in different countries, but all of us are exposed to different kind of like emission sources by different their specific characteristic. So this is the information and the news is published in Indonesia. So based on news mentioned about the air pollution affect all ages of Indonesians, and no one can really escape it. So based on the researchers from the right, they are trying to understand possible emission sources in different cities. Actually, I tried to find a good job, but I couldn't really find it from the report. But from our pictures, they highlight the major emissions in Indonesia are traffic and the biomass burning. It's almost occupied more than half of percentage in different cities in Indonesia. So if you think about the daily life, we're using like scooters or car drivings, we still produce a lot of emission sources like for the air pollution. And if you do like the cookings and so on, they will still produce a lot of air pollution. However, this kind of like daily behavior, how will that be affected our life? So that's a big issue. So based on the reports in 2020s about the situations in Indonesia, Jakarta, it's estimated about more than 13,000 of premature death, and the cost now. And the cost will be 3.4 billion US dollars for like a healthy burden. So it's really a lot. So how we can really avoid it and how we can improve our health, as it will be a really challenging big issues. It's not only in Indonesia, it's also in other countries, even like Japan or like US or Europe, and as well as Taiwan, of course. So before we go further, what is air pollution? Actually, air pollution is the gas, dust, film, odors. That is a handful of amount which is affected on humans, animal, plants, and so on. So it's almost cover everything. It's not only affected on human, it's also affected like the plants, some such like vegetables, if it's burnings, wildfire nearby the farming produce a lot of particles. Probably the particles contain metals or some like organic, and this settle down or deposit on the solid, so being absorbed on the ground. So this convection will be affected by air pollution as well. So a lot of studies are looking at how the metal stable on vegetables as well. So if we go back about 60 years ago, actually no one really understands what is air pollution, but this is the first historical record in our history. About 60 years ago, we call it Great Smoke in London. It's 1952. So due to the industrial evaluations, so people need to burn the coal to produce the power for the steaming. So most of like the industrial company or manufacturers, they should be built nearby the Thames River. Based on the situations in London, because it's cold and the weather conditions not good enough, so this kind of emitted air pollution cannot really be deterred well in that date. So in December 5th, 1952, so a lot of patients, they go to the hospital. And the doctors don't have idea what's happened. So during these days, it costs about it costs about like 4,300 deaths on that day. So the epidemiologists want to understand what happened. So they use a very simple trend graph to see what happened between this death and the air pollution. So they notice that when like the air pollution increased, it also increased with the pneumonia, bronchitis, and heart failure during that days. So that raises the questions for the epidemiologists or like scientists. They think about what happened during this period of time. Is that really like air pollution or is the other factors? So after about 15 years after, a lot of resources conducted in Europe, in the US, by different types of cohort. They try to understand what happened by more advanced epidemiology approaches. They found air pollution increase the risk for cardiopulmonary disease, especially focusing on like the chronic pulmonary disease or like the cardiovascular disease and so on. So in that case, you can see when the air pollution increase, it also increase like chronic pulmonary disease such like asthma, COPD, morbidity or mortality. Actually, for the clinicians, they are more care about the asthma because it's like more high prevalence and it's reversible, and there are lots of like medication that can be used for treating the patient. But for the COPD, that's the other side, because when this patient being diagnosed as a COPD, the clinician or medical doctor treatment try to maintain the lung functions and try to reduce the risk of like acute suspension. However, these lung diseases are irreversible, which means when it's being occurred, we only can maintain the lung functions, not getting worse, but there's no medication used to let the patient's disease or severity getting better. So based on like a report I mentioned about 384 million patients in suffer by COPD, and it's a third rank of death. And then lots of risk factors, and such as like smoking, outdoor air pollution, or like occupational dust exposure. Lots of factors that are associated with like exposure, derived or indirect, and leading to COPD. So as I said, traditionally we think smoking is a major risk factors that contribute to the COPD development. So based on experiment design, if we use like a retrospective experiment design, which means we collect a COPD patient and to see how's the smoking histories in their previous time. And based on the report, we can find about 80% of like COPD patients they have a smoking history. So this is for like a retrospective design. However, if we do a cohort study, so we collect a group of like healthy subjects, and some of them are smokers, some of them are not smokers. Follow a period of time, such like 5 years, 10 years, even longer, to see the incidence of like COPD. There is only about 40 to 50% of the patients are smokers that are related to COPD development, which means if we're using different experiment design, you probably have different results in terms of like the percentage change based on risk factors in both. So this is the answer for the mention about globally about 55% of COPD subjects they are non-smoker, which means it's still a huge portion of COPD they are not really related to the smoking exposure. So that means air pollution, occupational exposure, or genetic background, or like a premature, like a lung development, and so on. A lot of risk factors that are really associated with like COPD. So in our lab, we started to understanding what happened about like COPD development. So we collect occupational cohort from a shipyard worker. So we do the case follow-up more than 10 years already. So this is the first report. And based on result, we found a lot of workers that have been diagnosed as like a COPD after 4 years. And we can see the incidence rate is about 2.5. And then huge portions of them are not belong to the smoker. So that means probably due to like occupational exposure, such as like weldings or like paintings and so on, because they are exposed mainly to like welding particles or like chemicals and so on. And if we look at the types of work here, so we can see about 2.9 for this So based on so that means it's very identical we can identify what's the risk, what's the outcome, because half of them and this is very difficult because they only So when this particle inhaled into a lung, what happened? Because the pathogenicity changes in COPD subjects, they are not subjects. The lung function declined, air trapping, emphysema, and so on. So that leading to the airflow changes, more particles are able to based on report, the particles are able to like lower airway and distal lung in subject compared with the non-COPD. And the lots of particles are being trapped into pulmonary regions, such as the head and so on. So if we look at like the lung disease, such as pulmonary disease, it's not only the disease or treatment only, it's probably associated with identity and so on. Because more particles being trapped on this problem, such as we call it sleep apnea, this kind of disease has been related to the air pollution as well. So what happens if a particle being inhaled into our lungs? A lot of particles trigger our immune response, oxidative stress, or inflammation. So this is a report published in Circulations. They hypothesize three main mechanisms that are being related to air pollution exposure in response to cardiopulmonary disease development. So first is a pathway when particle inhaled into a lung, now leading to a local inflammation in the lung, then leading to the systemic inflammation or oxidative stress. So from the lung first, so some people call it lung inflammation, and then leading to the secondary inflammation in our circulation. And the other one is when particles inhaled, how we can change our nervous system. So a lot of study they has been reported an air pollution exposure that will lead into a neurodegenerative disease, changing our CNS system and so on. So these kind of particles can either directly or indirectly to affect our neural system, leading to the central nervous disease or neurotoxicity. And most important for the pathway 3, because the particle, if it's smaller enough, it's much easier to be inhaled and penetrate into our distal lung. And some of particles are either directly or indirectly and can be penetrated or translocate from alveolar to our circulations. So can lead to the secondary organ disease, such as some report identify the particle can be identified, can be observed in kidney, in brain, in heart, this kind of secondary organ. So that would be much important if we can get more concept about the three mechanisms of particle exposure. So when particle being inhaled and leading to inflammations, oxidative stress or CNS or a particle translocate to the circulations directly, leading to disease. What happened? So based on the report, we identified the particle PM2.5. PM2.5 means particle matter less than 2.5 micrometer in air diameter. So when this particle being held into the lungs in COPD structure, we can see the risk for COPD is increased for the main concentration, and then it also leading to the lung function decline as well. But for the difference, things for the high and low during the day, so we call it a fluctuations. So for the difference, we see there's still some association can be observed, but it's not so significant based on this study. But if we're looking at the dose response, we can see when more particles we expose and higher risk for the lung function decline or COPD development in the short period. And if we're looking at the difference, it's percentage usually. So in terms of our response, if we expose to the air pollution such as PM2.5, we probably have a different kind of physiological responses after exposure in COPD subject. And that will be very interesting. So if we go further to looking at inflammation type in COPD, most of patients are belong to the neutrophil inflammations, but there's still about 20 to 30% of COPD subjects. They are preceded with the highly neutrophil inflammations in COPD subject. So about 10 years ago, there's still controversial between the treatment. They're talking about what's the difference between asthma and COPD. Because some patients of COPD, they share the same phenotypes with the asthma, because all of them have a neutrophil inflammation. But about 5 years ago, a lot of biological drugs have been developed for treating the asthma patient. So for this kind of pharmaceutical company, they try to understand it. Is that able if we can use the asthma biological drug to treating the COPD patient with the neutrophil inflammation? But most of the clinical trials have been failed. So the pharmaceutical company, they will think about the strategy and to identify what's the we call it primary outcome for our immunology experiment design. So they think if we change our concept because it's irreversible for COPD subject. So if we apply the biological drug from asthma to COPD, probably we cannot really look at it as a lung function only. So based on the secondary analysis of the data, they found if a COPD subject treating with like a biological drug, they can reduce like acute suspicion rate in COPD subject who is highly eosinophil inflammation. So now more and more like a report being published and the clinical trial being successfully for the phase 3. So there's some biological drugs that can be used for treating the COPD subject now for like a COPD inflammation. And they need to fulfill the requirements such as like the patient's blood eosinophil should be like higher than 150 or even higher for like 300. Because for these subjects, of course, I mentioned about only 20 to 30% of COPD subjects they have the like eosinophil inflammation. But in these patients, they are so special because when the high eosinophil inflammation, that will be increased about 32 of the risk for acute suspicion. And for this patient, if their eosinophil persists highly, more than 300, it's about 99% of COPD will readmit to the hospital due to acute exacerbation. So that means it's very important issues how we can control the eosinophil inflammation. Because when patients recover for acute exacerbation, their lung function will be quite continually. Here, the quality of life decrease or to the death. Based on the study, we identify from the animal because we spend a lot of time to do the animal work. But today, all the slides are talking about epidemiology. We identified when the mice is exposed to certain type of like air pollution emission sources, their eosinophil was increased. Or the mice exposed to higher temperature, their eosinophil also increased. But if they exposed to like a cigarette smoke, their neutrophil was increased. So it means different type of air pollutions or different type of like behavior such as smoking, biomass burning, occupational exposures to leading to different type of like inflammation COPD subjects. So that was a question to us. Is that able if we can really identify what type of cell inflammation that are really related to air pollution in COPD? So based on reports, we found eosinophil inflammation COPD subjects are much more higher risk in response to air pollution. COPD subjects, you can see after a month exposure to air pollution in eosinophil inflammation, especially in the top 3 and 4 stages, they have a higher risk for like COPD. So that gives us an evidence like for the air pollution exposure, probably they will be risk factors for increasing like eosinophil in COPD subjects, then that leading to higher risk for acute exacerbation. So based on reports, we identify if the patients that being acute exacerbate and they have higher air pollution exposure in the past time, and if we determine the metal level in the blood, they have higher metals that when compared with the non-acute patients or like a non-COPD subject. And such like copper, zinc, irons, and so on. Some of these metals are dominant in air pollutants, like the metals and so on. And this is very interesting study for the IDR group. They found when the COPD subject being acute exacerbate in hospital or in the ward or in ICU, it takes longer time than exposed to lower levels. So they have found about 3 days delayed for air pollution exposure at high levels and need more time to be discharged from the hospital. And for the recovery time, it's increased about 15% when compared with normal. So that gives us an idea about if we link the first slide to the slide here, air pollution increases the risk for COPD, and the certain types of air pollution are probably leading to like eosinophil inflammation. and then leading to the risk increase for participation and for conditions. You will probably find that some patients are not easy to be treated, even if you give like a drug as usual before, but they probably need more time to stay ICU or in the ward than be discharged. Probably it's due to like average exposure. And then different types for COPD. So based on the GO guideline, they published like if we look at the type for COPD, one is for the genetic background, such as like alpha-1 antitrypsin. The other one is for like abnormal lung development, such like for like a pregnant woman who's smoking at stages that could be causing like lung development disruptions, or like a lung development premature, this kind of things. Then the other one is for the cigarette smoke, COPD, we call it COPD-C. And the interesting in the GO report, they mentioned about the biomass and the approaches that is different when compared with the smoking. And that can be categorized as like a COPD, is for particular matters or pollutions. And the next is for the infections or COPD with asthma or unknown causes. So if we're looking at the different types for COPD, there's still some types probably that belong to the COPD. However, which type? We are still unknown, because for COPD, there are two main pathology changes. One is for like the bronchitis because the several or continuous fibrillation or triggers by the oxidative stress or like contamination, so leading to an airway wall thickness increase. So it's bronchitis, and the other one is emphysema. So small particles being held into a lung, and that will be able to interact with our alveolar epithelial, so leading to alveolar epithelial gas or like A2 cell, type 2 alveolar epithelial dysfunction. So that means this kind of progenitor cell dysfunction, so they cannot really differentiate into the A1, type 1 alveolar epithelial. So leading to this kind of like structural cone-like structures being destroyed. So this is study published in JAMA. It's very interesting. They use a two-task experiment design, and it's very common now for the high-ranked journal. So first of all, it's like a core study. So the baseline and then include they use a cross-sectional study, and they try to understanding what happened for air pollution exposure in the previous time. So they're looking at the risk for air pollution in COPD with emphysema progression or emphysema. So first cross-sectional study, they identify like other matters, ozones are associated with emphysema development based on cross-sectional experiment design. And after 10 years follow-up, they are still trying to understand it. The emphysema progression is not really related to the original identified air pollution or not. However, if we're looking at the 10 years after, we can see only gas pollutants are highly associated with like the emphysema progression, such as like ozone or nitrogen dioxide and so on. So gas pollutants are highly reactive, and it's much easier to see the injured or damaging lung and leading to the emphysema. Based on this report, and in our group, we also done a meta-analysis, try to confirm it or try to find is that true. But based on the meta-analysis report, we cannot find any association or significant association for case 0.5. But we still can have the same result as the JAMA report. We identify like ozone is much more associated with the emphysema. So what happened in our lung? Because gas pollutants are being identified as a risk factor for emphysema development. How about other matter? Because lots of people are talking about other matter. So we go further, try to understanding what happened on the rule of the other matter of the climate change. Before I go to the climate change, I want to emphasize the importance of the climate change. And extreme weather events are very important issue, especially this year. In May, in Taiwan, the temperature will be around 20-ish, and it's a rainy season. But in Taiwan, during the May, the temperature raising about 40 degrees. It's almost 5 to 10 degrees higher than usual, and there's no rain. But till this month, that is June, the temperature will be reaching about 30-ish degrees. But the temperature in Taipei is around 22. So I still wear a coat in Taipei, and I will show like now. And the rainy season seems like a shifting. So it's raining a lot in Taipei, but the raining is not as usual as raining because the usual rainy season in Taipei is light rain, but now most of like heavy rain just suddenly very heavy and start very quickly, just like the storms in the summertime. So everything seems to be changing. So if we're looking at the report like for weather forecasting, they forecasting that this year is getting hotter than usual throughout the world. And this is a report from last year. They talked about a heat wave that could be across Europe and leading to a lot of like severe condition and increase the morbidity mortalities in Europe. And Indonesia, there will be last year, since like the hotter in April, 40 years ago. But the weather today, I think, is very comfort, but I don't know how it happened, probably in the summer. And that will be a lot of like typhoon or hurricanes in Asia or in the US. So before we go further, there's a report for the medical students. So they do a questionnaire asking the question, how do you think about the climate change? Is that associated with your clinical diagnosis, or is that really associated with daily life or your study? So about half of clinicians or clinical like medical students, they have moderate knowledge about climate change, and then even less, they don't think climate change will be really associated with their clinical diagnosis because they just need the patient and give drug, give diagnosis. However, if we're looking at like seasonal variation, seasonal changes, you probably find there's some patients are getting more common or difficult treating. You can think about it probably like due to like common changes that leading to like a more infection diseases in Asia, or like more like mold and leading to like infections in and so on. And this is temperature increase in Indonesia is about 100 years from the 1901 to 1922. The temperature increased about more than 1 degree over the century. And more and more like a climate change event, we call it extreme weather event in Indonesia or in the other countries. It's not only happening here, actually it's happening throughout the world. But if we want to identify what is climate change, including all the factors here, such as cold, hurricane, cold spell, like a storm, sunstorm, typhoon, heat waves. So it's not only about the temperature, it's also about like the humidities, so on. And temperature and humidity are very important factors that can regulate the pulmonary health. So this is a report from like a UNDP. So they talk about 32 of global extreme temperature events that occurred in Asia, and 84% of deaths have been accounted for due to changes. And for the existing disease, such as like cardiopulmonary disease, they are more sensitive in response to like climate changes, and leading to approximately 74% of deaths in Asia region. So based on lots of like reports or meta-analysis has been identified, the people who live in Asia are more vulnerable in response to climate change. So this is news in Indonesia talking about more and more to like how wave you need to be prepared. I'm not sure how you prepare for the hard wave, but in Taipei, if you want to prepare, you just stay in air conditioned or reduce the time for like outdoor walking. So it's being regular, compulsory. If a temperature higher than like 38, 39, and the company cannot let the workers to working outside. They need to stay or to have like shift to avoid to expose to the sunlight, right? Reduce this kind of like stress. But it's very important here. Based on the report, some clinicians they know asthma, COPD are seasonal disease. So we use the seasonal disease to describe everything. Because when the season changes, the patient will be coming, such as like in Taipei, the temperature changes a couple days after, there will be a lot of patients go to the clinic or the hospital for the visiting, or more like anticipation after like a couple days later. So the keyword is couple days later. Now the random, if the temperature changes a couple days later. But if we're looking at the trend, that will be different. For asthma, you can see the down and up, the trend are much smaller when we compare with the COPD here. It seems like COPD are much sensitive in response to like a season. So what happened with these seasons? So every season or every country have their unique weather conditions, but normally when the season be changed, there are two things will be changed. One is humidity will change it, more humid or more dry, or high temperature, or low temperature, more comfort. So this is a report from UK. They mentioned about more heat wave that leading to increase of like mortalities in UK, and it's almost 10 times higher in 2080 when compared with the 20th centuries. So two factors, I say, temperature, humidity. So if we put three factors together, temperature, humidity, and air pollution. So when more air pollution it be generated by our daily behavior, such as traffic, biomass burning, industry, and these kind of pollutants be emitted into our sky atmosphere. And it would be reacted with like a sunlight UV to generate ozone or the other types of like air pollution, such as like we call it secondary organic aerosol. Secondary organic aerosol is produced from a gas pollutant. And when the temperature increase, it kind of like exacerbate or increasing the ratio or the rate for these pollutants to increase. And more particles being increased under the extreme temperature, like high temperatures. That means higher pollutants can be produced in our life, our site. But when the particle increase, probably it generates a lot of like you will see the sky a little bit hazy, cloudy. So that means here there will be a lot of aerosol particle can reflect the light. So you will see the temperatures or weather will be cloudy, we call it cloudy. So the sunlight will not be so directly so strong. So if you're a little bit comfortable because the temperature probably increase. However, that will be causing like a humidity decrease. So when the humidity increase, the particle will getting together, called particle growth. So from a small particle to produce large particles. So a lot of factors that interact together. So what happened in terms of like the humidity, temperatures, air pollution in response to COPD? So we conduct a meta-analysis to try to identify that extreme heat, extreme cold, now be increasing or related to the morbidity or mortalities of these subjects. Based on the result, we found extreme heat is increasing about 16% for the mortalities. But if we're looking at the extreme cold, it's increased about 47% for the morbidity and 32% for the mortality in general for the COPD subject. We go further to look at the subgroup to see is there any particular gender or region or ages that is more vulnerable to climate change, air pollution, or extreme cold, extreme heat. Based on result, we find if the female is exposed to extreme heat, their risk will be higher than male for COPD subject. And the elderly, which age more than 75 years old, and in terms of like a region, see the Asia and US. The people who live in Asia and the US have higher risk under climate change, like such like extreme heat. That's if you can add a code, two genders, male and female, so it's quite equal. Like compared with like extreme heat. And for age, it's between like 60 to 75 who have like higher risk, and in Asia regions. Because supposedly people like the US or Europe, because the temperature are much lower, so the people in Asia are more used to the hotter environment. But when temperature are being changed to the cold, we probably would not have like a way of adapt to this kind of like, cold temperatures in Asia region. And we want to see if we adjust the age, how the mortality changed. COPD in response to climate change, we can see when the temperature increases, the risk will be increased as well. And like humanities and from 5 are really associated with like age adjust in COPD subject. So that was very interesting work. We do like a mediating analysis. We try to looking at what's the factors that mediated the air pollution. Based on hypothesis, the temperature changes, humidity changes. Now we change the production of like aerosols, such like secondary organic aerosols in the sky. So we found when the humidity increases and produce more like gas pollutants, such as the nitric dioxide, and that leading to regular function changes. And the temperatures produce more particulate matters and causing upstream desaturation, and leading to emphysema in COPD subjects. So try to using a mediating effect looking at how this kind of like temperature humidity changes the air pollution and leading to healthy outcomes. And if we're looking at the shorter fluctuations during the day, we found when the humidity changes and leading to like 10.5 increase and leading to the renal function right during the short period of time. And we also identify is presenting the U-shape. So why the U-shape is important because based on U-shape, we can identify what's the threshold for the temperature of humidity. And based on the threshold, we can see if it exists, the threshold, that means the risk will be increased. So we can get a point to try to provide more evidence for the government making the decision as like the policy. So if we the last few slides, so how we can really dancing to climate change and our health. So first of all is we understanding what is the risk population at risk, such as like the children, elderly, existing disease patients, they are the population at risk. However, for the healthy subjects, it doesn't mean we are really healthy enough to detect or to prevent the climate change or air pollution event. And there are lots of factors we need to know, either for like the populations, for general populations, or for like the student, for conditions. You probably need to know there are lots of risk factors that are related to disease, such like some are related to asthma, some of are related to COPD. Then if we have enough concept or knowledge, then we can persuade the government to change the policy and to increase, we call it adoption or resistance. So there are lots of health outcomes that could be affected by air pollution or like climate changes, such like the lung, heart, brain, and so on. So the last slide, the air pollution is a risk factor. So for COPD, especially for the non-smoker COPD. And climate changes is very important, and we need to understanding what will be the vulnerable patient or vulnerable population, which is called the population at risk. And adoption is very important. How we can really adopt the climate changes such as like a humidity increase, temperature increase, or air pollution increase. For example, wearing the mask is one of the strategy that we can adapt the environmental changes. But in the general environment, such as like temperature increase, humidity increase, how we can adapt it, that will be a key issue that we need to think about, and we need to spend more resources to understanding by research. So adoption, the one is to protect ourselves. The other one is we need to do an early risk identification. I think it's very important for public health because public health is to prevent disease happen. So because my background is public health, so I spend a lot of resources and spend lots of time to looking at the risk factors and how we can reduce or to provide more evidence and to like the general populations or for clinicians or for the government, and they can change the policies by changing policies and to let people to avoid this kind of like a disaster or climate change. And the other one is preventive intervention, is for the conditions. So how we can prevent it? So first of all, we need to know the patients for COPD is exposed to air pollution. You probably need to forecast the patient will be slightly or much more difficult to treat than the normal patient. And so asking the living science is very important. I'm not sure it's important or like clinical practice in here, but it's very important in Taiwan. When patient coming, you need to ask him almost everything. So do you smoke and where you live and how you cook and like what's your job and how many hours you spend outside. So you get whole pictures of the patients, then you probably can give more clarity for understanding the risk and then to give the better prescription for medicine. And the other one is for the research, personalizes like a patient care, such as we can have like a drug development. Now we'll be treating for the patients who is more sensitive to climate change, to air pollution, or like we can identify which phenotype is more related to air pollution. Oh, we can using the AI, this kind of approaches to help us for patient diagnosis. I think it's very popular nowadays because for the AI, it's being involved in Taiwan in terms of like a medical system. So the patients will be, the tradition, as I say, will be asking questions by the doctor, but now they need to fill in the questionnaire by CAT. And this kind of questionnaire can be analyzed into AI first. So the doctor will get a report to see how the risk for the patients before they really face-to-face for the diagnosis. And that'll be the last pictures. And it's my first time to visit Eugene, and it's an honor to be here. And that will be the peers, and if I'm right, it's president or vice president for the visiting.
Rector. The president, yeah.
The president, yeah.
President.
And it's for Dr. Farah and for the visiting, and we have a post for this one, right? I'm right. Yeah, I'm really happy to be here again. And thanks everyone, and thanks for the funding sources, and thanks for research group in our team. Thank you very much.
Yeah, as we can see here, Professor Chong is involved in many activities, and one of them is also, as mentioned before, as the supervisor for the Indonesian Student Association there. So yeah, we have Indonesian representative here. So yeah, as we can also know that Professor Chong has been here several times, and this is the third time provided by the Master in Biomedical Medicine and also Master in Tropical Medicine. So thank you for the collaborations. So we now can open a discussion session. So please, if you have any questions, either from the offline participants or from the online participants as well. We have about 19 participants from the online. So yeah. So if you have any questions, please raise your hand. It's up to you. You can ask any questions. we have covered a lot of topics here today. Yeah, please welcome.
Thank you for the opportunity to participate. Thank you for the lecture, Prof. Chuang. My name is Puspita from Anatomical Pathology resident. You mentioned that higher particulate matter concentration and fluctuation are associated with worse COPD outcomes. In my province, in Central Sulawesi, we have nickel mining, and in there has extensive nickel mining and smelting activity that generate PM 2.5 and PM 10. And my question is, could long-term exposure to this particle contribute to an increased risk of COPD or accelerated lung function decline among nearby residents? And my second question is, what preventive measure would you recommend to reduce this health risk? Thank you, Professor.
Okay, thanks for the question. I try to find this. Okay, at this side. So it's very similar to this one because for like mining, they exposed to dust, of course, and it's very interesting. I think it's also sharing the same concept. If we're looking at COPD, it's the shipyard worker. So they main job is doing the welding. They produce a lot of like welding particles. Of course, the OSHA has been some regulation for the welding fume exposure, but for the welding fume exposure, it's kind of like a short-term symptom. So it's been thinking about the not so important kind of like a technical meaning of diagnosis. But after a couple of years follow up, we can see supposedly it's being compulsory to wearing the mask. So we call it a personal protective mask. But there's some result in here. We can see if the patient, sorry, not patient, if the workers wearing the PPE, the mask or not, the incidence rate are quite similar here. You can see yes or no, it's about 2.5 for the incidence rate. So either the workers do not really wear the mask properly, or they need to change the mask more often. This depends on how the levels of the pollutant exposed, because this kind of mask, they have their own capacity, but its existing capacity probably is not really enough to provide to protect the workers' health. So that's the first thing. So for like a nickel is very important for like disease, because nickel can be generate static stress by factor reaction, and this has been recognized as a major source for static stress. So when this kind of particles being held into a lung, that it into like disease, and it's not only for the lung, it's also associated with the other kind of disease as well. And how we can really prevent it. So in general, of course, wearing the mask, but wearing the mask correctly is hard for the working environment. So it's very uncomfortable. So for healthy workers or like the newcomer workers, their awareness, this kind of environment are really dangerous. So they only really more concerned about comfortable or not. So they probably will wear the mask, but put the mask in the like a throat, not really to cover their nose. That's a big point. So wearing the mask correctly is very important. And then for like companies or for like managers, they need to provide the accurate PPE, the mask for the workers. And the third one is because like mining, it was a major industry in Taipei. So take my family, for example, My grandfather was a miner in Jiufen. So that's all like a disease, respiratory disease happened. So for my father, they moved from the mountain, from Jiufen to Taipei City, try to having their world like a business. So the other thing is because the PhD in Taiwan not on mining, so the government get more notice and concern about how to prevent or to reduce the risk. So now it's compulsory to have like a health examination for the general a year. But for this kind of like we call it a spatial working environment, such as like chemicals, heat, exposed environment. It's required to have a year for the health examination and shifting. So some of them probably need to shift if it has been diagnosed as like some illness, but not to disease yet. So early diagnosis and try to do some preventions, I think it's much more important than to treating the patient because it's like this kind of like the disease we have by the dust. Most of it are now treatable.
Yeah, very much for the question and also for the answers. Is there any question or we can continue for the online for the moment? Oh, yeah, please. One question.
Thank you for your insightful lecture. My name is Cynthia and I'm a pathology resident, anatomy resident. I will ask you from a public health perspective, if a country has unlimited resources like Indonesia, should it prioritize reducing air pollution exposure at the population level or strengthening the climate adaptive healthcare service for high risk group, and which strategy will provide the greatest health impact? Thank you, Prof.
Okay, sure. I think it's very good questions. It's difficult to do everything at the same time because there's some like a retraction, such as like the resource, general knowledge, and so on. So I think the most important thing is for the student or faculties, probably we need to have a concept to notice that air pollution, climate changes is things that we cannot really avoid. And we need to prevent it by ourselves, either by teaching, because as a teacher for me, I think the most influences side by me would be the teaching. So how to teach your student, teach your like your children, or that your family knows about the importance of air pollution or climate change, and how you can prevent it, protect yourself. I think that's first step by education. And education is not really related to the public resource or like research funding, because if it is very critical in Taiwan. Every time when the elections coming, it's coming this year. The air pollution issue will be raised by the politicians. They are quite challenged about like in Taichung, the highly polluted areas where the government put the less resources, they done nothing. So the opposite party is so kind of like attack them by this kind of issue. So it's happened almost year by year in Taiwan. So when they attack it, they put a lot of like the news and so on. So that enforcing the student or the children to really get understanding what is air pollution, what's a harmful or air pollution. So if they have this concept, I think it's kind of like a part of the education, educated in like the public media or from the lectures. That's the thing. So if we know that, or more people know that, the first thing would be we probably know how to protect ourselves by wearing the mask to avoid highly polluted area, because sometimes it's like a fire warning nearby. For our curiosity, we're close to the fighting building or fighting place, right? To see what happened, to making a crowd. But if you have concept, you probably will stand far away, not really close to, because you know it's dangerous to your health. So the first thing is the knowledge. And the other one is we may need to think about for like a kinship diagnosis, how we can identify the population and risk, and it's called like medical education for patients, because most of patients they don't have this kind of knowledge. So trying to spend a few more minutes to let the patients understanding how we can reduce the symptoms or reduce our frequencies of this kind of like a severity or acute by like reducing like burnings or to stay the more times indoor and so on. And then lots of different strategies. So try to provide something that would not cost too much. And then of course the last one is the resources such as like when more people knows about that, so that will force the government really facing the issue, then they will do something. Of course, I know it's not easy, it takes time, but at least there should be someone to really stand up and to pursue the government to really think about the development. It's very important, but how we can find a balance between the health and the business or like economic development. Thank you.
Standing. Good afternoon, Prof. Thank you for the lecture. My name is Twin Tomo from the anatomical pathology. And I am feeling nervous because tomorrow I want to present my thesis with you, Prof. I want to ask, Prof, is the effect of pollution on COPD for you? If simple, if air quality improve, or can some of the things persistent of long term? Thank you.
Yeah, that's a very good point. So based on the results, based on study, we observe if we're looking at the short term for like a healthy subject or like asthma. Of course, COPD is irreversible for the lung function. So if the air pollution decrease, that will be leading to slightly improvement for the lung function or for the symptom. But it's a net effect. It's not increased today, then your symptom will be suddenly improved. Yeah. So I think it's still doable.
Okay, thank you very much. Is there any other question? Oh yeah, please.
For this opportunity. My name is Universitas Gadjah Mada, and I am a master student from master program topic contamination. And I want to ask about the how does increased COPD exacerbation driven by air pollution contribute to limit antibiotic use and accelerate an MR right now. And to what extent may the environment exposure reduce treatment effectiveness in COPD patient? I think if you have the previous study investigating this relationship, I want to know this and next this question.
So for the first question is talking about like medication use for COPD, am I right?
What
The first question is to
the relation COPD patient
medication drug use.
Pengaruh dari polusi udara terkait dengan para penyakit COPD dan relasinya terkait dengan penggunaan antibiotik nantinya untuk penyakit lainnya. Apakah ada relasinya untuk penggunaan tersebut mempengaruhi dari pengobatannya ke depannya untuk COPD, semakin berat atau tidak?
So, if I can summarize, so it's about the relation between air pollution and COPD, and how because one of the treatment medication usually is we can also give antibiotics in some cases. So is there any relation in the outcome of the patients with if they are provided with antibiotics as well? Maybe change the microbiome or something.
Okay. Yeah, yes. Okay, it's very good questions. So the first thing is we have the other report being published, and we are looking at acute suspensions in COPD subjects and by the drug used, and how would that be related to air pollution. So the similar results we found the COPD patients that with higher air pollution levels that need to more days for like drug or antibiotic prescriptions, and that means they need to spend more days in the ward or in the ICU as well things. And based on our recent results, and we identified that air pollution affected our lung microenvironment, and we try to understanding by different animal models. One is like a control, one is the animal given the antibiotic for a month, then followed by the like exposure, medical matter exposure to see what happened on microbiome. So that gives us some evidence that the air pollution really affected on our lung and could change like microbiome as well. And if we looking at like antibiotic, there will be two issues. One is like antibiotic will be kind of like being cold work with the particle matter, so totally destroy the microbiome in the lung environment. And the other one is the antibiotic. We identify it particle matter itself. It's surprisingly we find antibiotic can really be carried by particle matter itself, but where's the antibiotic from like water, wastewater, because some like hospital wastewater they drink it, but not really manage it well. So leading to some like low levels antibiotic in particle matter. So that means particle matters with antibiotic being carried by lung, that could be leading to more severe like injury or insult.
Thank you very much. Is there any other question? Or I think we have some questions from the online participants. Can I read it? So the first question is, if I may, do you think that air pollution may also be responsible for the increase of lung cancer incidence, mainly to non-smoker? And then if yes, what possible future study that can be done to prove the association of air pollution and lung cancer in non-smoker?
Yeah, it's a very important issue in Taiwan because the top 10 death in Taiwan, the first one is lung cancer. The most important is adenocarcinoma in Taiwan. So traditionally, we think about smoking, same as COPD. Smoking is a major risk factor for like cancer development. But the government spend lots of resources and lots of people are really looking at association between lung cancer and the air pollution. So they collect huge populations who is non-smoker and to looking at what happened by air pollution exposure. And they identify air pollution is a major risk factor. Actually, the concept is similar as COPD. Air pollution is a major risk factors that leading to lung cancer development and leading to like gene mutations such as like EGFR mutation and so on. And that will be mainly contributed by like organic factors in particle matter, such as we call it PAH, polyaromatic hydrogen carbon, PAH. And these kind of organic factors that will be activate the AHR pathway and leading to like mutations and so on. So that's the first things. And what we can do in the future, actually that's lots of things we can do. either for public health or for like the drug development or for personalized medicine. But nowadays, in Taiwan or more like in the other countries, they spend more time to identify things for the diagnosis. Can we get like a take abroad and to do the circulating lung cancer and to easily for diagnosis without like a surgery to collect biopsies and so on. So the first thing is to help in the detection for lung cancer. And the other one is AI. It's very popular in Taiwan. So like by HRCT scanning or like local CT, this kind of images can really adapt or being co-work with the AI system that helping the doctor for the diagnosis.
Thank you, Professor. And then we have another question here. So how does the climate change and its standardized mortality rates in COPD can connect the concept of long-term weather events like air pollution and emphysema? Like what is the proposed pathway connecting those? Thank you.
Yeah, it's very difficult because it's a lot of pathway that really involving like the humanity that probably associated with sodium channel because it changes the sodium channel, and for the temperature probably it associated like the Trump channel as well. So a lot of pathway that really involving, and the air pollution, of course, by Vincent's work, he identified like the eco pathway. So different kind of like air pollution of different factors that would involve in different pathway. But if we put everything together, I suppose that would be totally different. Yeah.
Thank you, Professor. And then we have two questions. The first one is just one. You mentioned about COPD in the goal study. What does it stand for, and what some examples of exposure that cause it? And then the second one will be, besides from extreme heat, is there any other extreme weather event that can cause increased COPD morbidity and mortality?
Okay, so COPD P is for particulate matter. So A stands for P for particulate matter, and the P of pollution. So P is covered like the biomass burning or indoor-outdoor air pollution. So it's being classified for COPD P in that group. And the next one is besides the temperatures, is there any like risk factors that are associated with the COPD morbidity or mortality or severity? Actually, most of the study are looking at the interaction between air pollution, particulate matter, and the temperature, because there are a lot of limitations by the models that we have, such as like we use 2-proton model, 3-proton models, and so on. And the other one, the most important, I would not say it's the most important, but the other important risk factor would be the humidity. If it's too dry, that will be leading to the airway dryness. And the airway dryness, that will be leading to this kind of like airway hyperresponsiveness and so on. So leading to more infections, bacterial loadings, and so on. So these kind of things are also associated with the disease severity.
Yes, thank you very much, Prof. I think for the question that we have done, is there any other question? Oh yeah, please. If not, then I want to ask questions.
So good morning, Professor. My name is Indri. I'm from Tropical Medicine. And first, sorry, my question, this may be a little out of topic, but as someone studying environmental health and tropical medicine, I sometimes wonder, like, considering that climate change, air pollution, and emerging diseases are becoming major global health challenge, do you think professionals in environmental health and tropical medicine will play a more central role in the future healthcare system? And if yes, what kind of expertise should we start building from now? Like, how should young professionals prepare for that role? Thank you.
Okay, good question. it's also the question that can be addressed by the students who study public health. In the Taiwanese society, because more resources are being focused on medical doctor. So as medical doctors say that they probably have like a more power to pursue the patients. But on the other hand, public health is very important because if the clinicians who want to do the study, either they do the wet lab for like a mechanism study, or they need to do the dry lab. So they need to go back to study public health. So public health or tropic medicine, I think it's the key or the major concept for building up your research skill, your research concept, and then you will know how you can design the study, or you can tell the data or the information that you get when you receive is true or not. So I often tell students that although I'm in a school of respiratory therapy, it's a more like clinical department, but having scientific concept for your future by learning epidemiology, statistical analysis, I think it's the basic skills or the knowledge that you need to have. Take like an animal study, for example. If you want to do the animal study, we need a control group, and the other one is a treatment group. So it's the same as our case control study. And for like the RCT, the muscular trial, it's very common for like the drug development, drug testing. They still need to have like the very good knowledge for epidemiology. So the same concept for tropic medicine, because tropic medicine is also part of like public health. So I think it's very important. So no need to worry about how should I say how many powers you will have in the future, because I think everything will be changing after COVID. They change it really fast. So please keep your core values. I think it's very important, and try to learn as much as possible during your study. Because after graduate, probably you will study Ph.D. or you will go to like an industry or a company or government for doing your work. So how you can pursue your client, your student, and based on the knowledge that you have. So try to learn as much as possible and to more confidence. I think confidence is very important. And then how we face it to the future. So traditionally for my about 20 years ago, not really 25, but 20 years ago, we using the SAS to learn the statistical analysis. So you need to write in the coding. And then I teach the student by using the SPSS because it's much easier. You just need to click the button. And now the AI coming, you just need to put the data into the AI, they give you the result. So the first thing is, I'm not saying that AI is bad. AI is very good and really helpful, but how you using the AI is very important. It really depends on how many you learn. So build out your abilities and try to adopt the technology that we have, especially for production. And the knowledge you learn, that you can help the AI give you the results is true or false. I think it's very important. So build out your core knowledge. It's much more important than how many skills you have learned, because things change too fast. So me, for example, my background is public health. So I do epidemiology, and for my PhD, I do animal study. So I do translation. I would like to say it's translation. For we get clinician data, clinician patient, and to prove a concept, and to do the mechanism study by cells, by animal. But now we are doing the AI as well, because everything needs to change it. So keep your flexibility and accepting the changes and improving your ability.
Thank you very much, Professor Chuang, for the motivation. Yeah, motivation. Yeah. But he is really a role model. Even when I was taking my study, he mentions a lot of mechanisms that I can explore to get my studies. So yeah, if I can I ask one question, because I don't see any other question left. I guess no more question. So I want to ask actually two questions. So for the first one, it is also interesting when I see this slide. So I was thinking like, is it so does it mean that personal protective mask does not really change the outcomes of the subjects? But then, as you mentioned, that maybe there is a possibility of the problem with the mask wearing, or even you have to change it frequently. So I guess that also answers the question. So, but this is for welding film. So when, especially for us students and others workers that are exposed to traffic jams, so I suppose we can take the message. So we have to wear masks every time, especially in traffic with the bus and everything. And then the second one is for predictors, because you mentioned that, for example, like smoking, it induces neutrophil, but then for extreme temperature and others, it induces eosinophil. So as in the clinical department, can we use this neutrophil or eosinophil to predict the outcome of patients? Professor, thank you.
That's a very good point. So the first one is wearing mask. So I think wearing mask is very important, and almost after COVID is our daily life, and especially in Taiwan, for the student, if they wake up late and don't want to spend time for makeup, they commonly wear a mask and only make up the eyes. So that's very common in Taiwan, and during like flu seasons, it's good to protect to reduce the risk for infection. So those are things. And the second one is sorry,
yeah, because for example, like smoking induces neutrophil, others induce eosinophil.
Yeah.
Which one is the best predictor for outcomes?
Yeah, so we spent a few more study, and that has been submitted for peer review already. So we're using like blood, white count for porphyria to see we use different ratio, such as like neutrophil to lymphocyte, eosinophil to lymphocyte, or lymphocyte to like lymphocyte to eosinophil, and so on. So we can use different combinations and to see how would that be associated or correlations with the disease or with the exposure. So we have identified certain types of like neutrophil to lymphocyte. Eosinophil to lymphocyte ratios are highly associated with like apparitions, and I think it's very useful because for clinicians, it's very common to describe the patient to take blood and to do this kind of like a white count biochemistry analysis. So we can use the ratios for further differentiation to help the doctor for diagnosis. So we in our lab we also looking at the present. Present is pre-COPD. So we can using different ratios of the white blood cells to see what the phenotype is that belongs to and all the risk factors.
Thank you very much, Professor, for the insights. So I think we have come to the end of the session. So can we give an applause to Professor Chuang? Starting from the concern of air pollution, and then how the mechanism and also the extreme temperatures and others, not only particulate matters but also the gas and the humidity can also affect the changes in outcome of the patients. So now we can come to a conclusion, and then we can take a photo together. So to commemorate this event together, so please welcome Dr. Farah and also all participants as well. So please join us to the front. Professor Chuang, please, you can stand in the middle. Maybe we can change the slide to something in the beginning or something. Yeah, okay. So we can. Tell me the number. I'll stand beside you as well. So please join us, everyone. Please go on the left and the right side.
The one who will check the exam tomorrow. Oh yeah. So okay. So we'll take our first picture, formal picture first. So 1, 2, and
Once again, 1, 2, 3, good. Smile, 1, 2, 3. No. Oh yeah.
Faster to circulate.
Kamera semuanya. 1, 2. Sekali lagi. 1, 2, 3, good. No, second blue.
oh EGM. Oh yeah. So you remember the EGM? Yeah, that's fine.
Still remember.
Okay, so we'll have the EGM pose for those who have not. Yeah. Okay.
Okay, 1, 2, 3, good. Look at the camera. 1, 2, 3. 1, 2, 3. Wait. Oh. Okay, 1, 2, 3, good. Once again, 1, 2, 3. Okay, thank you.
Thank you very much, everyone. Thank you. We appreciate Professor Chuang's presence for the public presentation. We are very grateful for showing us and present. Also, we are thankful for the Master in Tropical Medicine and also Master in Biomedical Science for the collaboration in supporting this event. So we would like to close this session and thank you very much all participants and Dr. Farah and Dr. Chuang for the presentation. So good afternoon, everyone. Thank you.
Selamat berlibur. Have a nice holiday. Have a nice holiday.
Oh yeah. Yeah, have good holidays.
Good holiday.
And thanks for coming.
Very good.